So good morning everyone. The topic of today's discussion is SCC with complete response to immunotherapy, their outcome and further management. Since this is a very focused topic, so I have tried to elaborate it further so that it is going to be beneficial for all. The outline of presentation is what is immunotherapy, who should receive it, what is complete response, what is the outcome of CR, and what is the further management of patients who have achieved CR. And finally, we will be coming to suggested algorithm in the end. Now, what is immunotherapy? As early as in 1909, it was found by Paul Ehrlich that immunosurveillance is a normal function of the immune system. That is, the finding and elimination of the cancer cells. It is normal function of the immune system. And the cancer cells evolve some sort of mechanism to escape this immunosurveillance, and this is known as immune escape. And there are certain molecules present on the immune cells which are known as immune checkpoints, the PD1, PDL1, CTLA4 and B7, which are the most important immune checkpoints, which are the mechanism evolved by the body to control this immune system so that it does not form an autoimmune phenomena. They control the activity of the immune system. And the cancer cells utilize these immune checkpoints to evade this immunosurveillance and progress further. Now, immune checkpoint inhibitors are the molecules which remove these brakes on the immune system and further boost the endogenous anti-cancer behavior. So these ICIs don't have any anti-cancer activity of their own. They just remove the brakes which have been applied on the immune system by the immune checkpoints, and they promote the endogenous anti-cancer behavior. So now coming to what is PD1, PDL1. PD1 is present on the T cells and it interacts with the PDL1. PDL1 may be present on the tumor cells or the antigen presenting cells. And suppose this is an antigen which is processed and taken by the antigen presenting cell. This is tumor antigen. This will be processed further and will, in relation with the MSC complex, it will be recognized by the TCR, that is T cell receptor. But this tumor cell also has got a PDL1, and which will interact with the PD1 on the cancer, on the tumor cell, on the T cell, and because of this immune checkpoint, this T cell will become inactive now, and therefore it will not be able to kill. There will be immune evasion through the PD1 PDL1 interaction. And what the checkpoint inhibitors do is that they block these molecules present on the T cell, the PD1 monoclonal antibodies such as nivolumab, or the PDL1 which is blocking the PDL1 monoclonal antibodies such as durvalumab, which will inhibit the interaction of the PD1 and the PDL1. So by inhibiting this interaction, the T cell will remain active and then will be able to kill the cancer cells. Now another ICI is the CTLA4 inhibitors. As we can see here, this is a T cell, and it requires two signals actually to become activated, so that it becomes activated. One is the TCR in relation with MSC, which is recognized the tumor antigen. However, post-stimulation is also required by the interaction of the B7, that is CD8086, present on the APC, and the CD28. When this interaction happens between the two, the T cell will become activated, and then it will be able to kill the cancer cells. However, the CTLA4 competes with CD28 to bind with B7. And the affinity of CTLA4 is much more than CD28 to bind this B7, and when it binds to it, the T cell will become inactive. But the CTLA4 monoclonal antibodies, they will bind to the CTLA4, so now the CD28 can bind to the B7, and it will lead to the co-stimulation, and it will cause activation of the T cell. So this is how the CTLA4 monoclonal antibody works. Apart from this, so the interaction, the combination of the PDL1 and the CTLA4 is actually synergistic. The PD1, PDL1 primarily happens in the tumor cells, the primary site of the tumor, and the CTLA4 actually acts in the draining lymph nodes. So if we combine these two, the effect is synergistic, although at the expense of more risk of side effects. Similarly, the anti-VEGF, that is bevacizumab, apart from inhibiting the angiogenesis, it also modulates the tumor microenvironment. So the combination of the VEGF also, along with either PD1, PDL1 or with the CTLA4, is synergistic in nature. Now, who should receive the ICI therapy? In various guidelines, it is advised that the patient who are having advanced SCC are the ones who are suitable for the systemic therapy, specifically the ICIs. And also in the intermediate ones, if they are having a suboptimal response to the local regional therapies or having some sort of contraindication, they can also be candidates for the systemic therapy. Now, what is complete response? In 1970s, WHO had devised some criteria for defining the complete response, which was subsequently then RESIST committee came up, that is response evaluation criteria in solid tumors. In 2000, they gave some criteria which was defined in 2009 and is known as 1.1 criteria. And in this, the complete response is defined as the disappearance of all the tumor lesions. Now, the local regional therapy that we give in the SCC actually do not cause disappearance. They just cause the necrosis of the tumor. So, the M-RESIST criteria came, in which the CR is defined as the disappearance of any intratumoral arterial enhancement in the target lesions. So, it is a bit relaxed. It does not require any disappearance, just that disappearance of the whole tumor. It just requires the disappearance of any arterial enhancing lesions. And rest all are the same, that is partial response, the stable disease and the progressive disease are the same between the RESIST 1.1 and the M-RESIST criteria. Now, when the ICI therapy came, it was found in certain tumors, specifically the melanoma and the non-small cell lung cancer, that when the initially first imaging was done, there was a sort of enlargement in the tumor size so that it fulfills the criteria of the progressive disease. Not only this, it also led to increase in the number of the tumor cells as well. So, but when this treatment was continued subsequently, it was found that these patients actually responded in the long run and have a deep and the sustained remission of the disease. So, this is known as pseudo-progression of the tumor, which is classically seen in the melanoma and the non-small cell lung cancer, and also some case reports of SCCs also there. So, the RESIST committee came up with the I-RESIST criteria. I is for immune, where the major difference is in the progressive disease. So, in the first imaging, progression of the lesion is seen. It is known as IUPD, that is unconfirmed progressive disease. And when the second imaging is done after 6 to 8 weeks, and if it still fulfills the criteria of the progressive disease, then it is known as ICPD, that is immune confirmed progressive disease. Now, coming to the oncological trials, in most of the oncological trials, the gold standard, the most objective thing and what is most relevant to the patient is the overall survival of the patient. How much a patient is going to survive after any intervention, because this is what is most relevant to the patient. However, there may be some logistic concerns regarding the assessment of the overall survival. The trial may be very much prolonged, or there may be some crossover design, or the patient may go for the second line therapy in case of suboptimal response. So there are certain surrogates which have been commonly used in the SCC trials. The most commonly are the radiological surrogates such as the objective response, which is combination of the patient who achieves a complete response and the partial response, or the recurrence-free survival, or the progression-free survival. And finally, we also have some biomarkers, specifically the alpha-beta protein and the PIVCA. But it is important to note that these surrogates are actually not foolproof. They have got certain limitations as well. There can be some sort of inter-observed variability in assessment of the arterial enhancement, and can be dropouts due to the toxicity. The pattern of progression can be different, can be intrahepatic or extrahepatic, multifocal or unifocal, and can be pseudo-progression as we have just discussed now. And also, there can be treatment-related dropouts because of the various factors. So, if a patient who has achieved a complete response by the imaging, it may not be that this patient has eliminated the tumor completely, and these patients actually should be followed subsequently. So, patient who has achieved complete response, it is important to know what is the criteria of complete response that has been defined in the study, whether it is radiological, whether it follows the M-RESIST criteria or the I-RESIST criteria or the RESIST 1.1 criteria, what is the AFP kinetic of this, whether the AFP is really decreasing or not, and whether it has been correlated with the pathological assessment of the tumor or not. If the pathological assessment is showing complete necrosis of the tumor, then it is highly likely that this tumor is not going to recur again. But on the other hand, if some certain viable cells are still there, then probably this patient can have recurrence of the SCC despite achieving complete response on the imaging. And certain questions then come that whether we should continue ICIs or not, how long we should continue, and what should be the follow-up, whether there is any possibility of discontinuing the ICIs in the long run, and whether this patient should undergo subsequent liver transplantation or resection to achieve optimum outcome or not. And also, because underlying liver is most likely cirrhotic in at least in 90% of the cases, we should be seeing whether there is any toxicity of the patient, of the ICIs or not, what is the underlying liver function, and the assessment of the portal hypertension. So, a very recent study published focused specifically on the topic of today's presentation, the outcome and the management of the patients of SCC who achieved complete response to immunotherapy-based systemic therapy. It was a multi-center study. Out of nearly 4,000 patients, 4.4% patients achieved complete response by the imaging. In various other studies also, it has been seen that the complete response is achieved in nearly 5 to 10% of the patient, depending upon the criteria used. RECIST criteria are a bit relaxed, so the frequency is somewhat more compared to the RECIST 1.1 criteria. Monotherapy versus dual therapy. Monotherapy has got certain less figures compared to the dual therapy, but it is more tolerable compared to the double one. And in this study, the median follow-up was close to 2 years, and 12% patient had to discontinue the therapy because of the recurrence. So despite achieving complete response and continuing the therapy, the ICI therapy, 12% patients still had the recurrence of the tumor. The 1 year and the 3 year overall survival was very good, 98% and 86%. And in some patients who subsequently went ahead with the curative intent resection, transplantation or ablation, 9 patients went ahead with resection or transplantation, and in the surgical specimen, 8 out of 9 had actually achieved pathological complete response, that is no viable cell was present in the tumor, in the surgical specimen. That means these patients are having very good chances of cure and very less chances that this patient will have recurrence of the SCC. But on the other hand, if we see that 1 year and 3 year recurrence-free survival in this study at the end of 3 years, at the end of 3 years it was close to 50%. So despite having a good overall survival of close to 85% at the end of 3 years, nearly 50% of these patients are still going to have a recurrence at the end of 3 years. In this study, the median age was close to 69 or 70 years, so it may not matter much because this patient already are having a very good overall survival. But had this patient had this study included younger patients, which we commonly see, then this figure is not good because nearly 50% of these patients are actually going to have recurrence of the SCC at the end of 3 years. Coming to the predictors of recurrence-free survival, there were the presence of macrovascular invasion and the presence of extrahepatic metastasis, which was somewhat confusing because these patients actually display a poor phenotype. Still then, these were the 2 independent predictors of recurrence-free survival, which was not explained by the authors also, and they just speculated that probably these patients had a very robust immune response, and this may be the reason that despite having poor phenotype, these 2 factors were the independent factors for recurrence-free survival. Now coming to the comparison of the RECIST 1.1 and mRECIST criteria, because there is certain issues related to the use of ICIs with regard to mRECIST criteria. There some arguments are made that these do not cause complete necrosis of the tumor, they just cause decrease in the perfusion, hypoperfusion, and it can look like a necrosis, but in fact it is not a necrosis. And especially it holds true for the bevacizumab. But in this study, it was found that the performance of both the 2 was quite similar, and this study provides sort of proof of concept that mRECIST criteria hold well even for the ICIs therapies. In fact, even the landmark trials which have been published, such as IMRE 150 trial and the Himalaya trial, they have used the RECIST 1.1 criteria for the primary outcome and not the mRECIST criteria. A very important finding in this trial was the patient who continued the ICIs despite achieving complete response for more than 6 months had a very good outcome, very good recurrence-free survival compared to the patients who discontinued the ICI therapy within 6 months. So the 3-year recurrence-free survival was close to 81% in patient who continued for more than 6 months, compared to 55% only in patient who discontinued the treatment within 6 months. So every attempt should be made if we plan to discontinue the therapy by any reason, because of the financial reason or any other reason, that these patients actually should continue the ICI therapy after complete response at least for 6 months. Similarly, another study which has a post-hoc analysis of the patients of IMRE 150 study and another multi-center cohort study in which this found it is assessment of the long-term outcome of the patient who achieved complete response. In the IMRE 50 study, as we can see here, the overall survival and the progression-free survival was more in patients who achieved complete response compared to the other patients. And similarly, in the multi-center cohort study, it was a similar finding. patient who achieved complete response had a better outcome. And also the patient who achieved a partial response, they also were better compared to the patient who did not even achieve partial response in both these studies in the long run. In this study, analyzing the predictors, the differences between the responders and the non-responders, no clinical factor was found to be predicting who is the patient who is going to have complete response. And also the assessment of the genetic mutations was similar in patients who achieved complete response compared to the others who did not achieve this. And interestingly, the circulating tumor DNA was lower in the patients at the baseline who achieved complete response compared to the other ones. So these are the new findings in this study. Now what about the combination therapy? Combining local regional therapy with immunotherapy, it holds great promise because they actually act synergistically. Giving local regional therapy causes exposure of the new antigens and sensitizes the immune system and enhances the subsequent immunotherapy. And as we can see in this study, 63 patients were there who had locally advanced unresectable SCC. They went ahead with some sort of local regional therapy, either in the form of combination TACE plus SBRT or SBRT alone in the patient who were having contraindication for TACE. And at the end of 4 weeks, they received anti-PD-L1 therapy or anti-PD-1 therapy. And it was found that the complete response was seen in close to 43% of these patients. However, there were 10 relapses, that is nearly 1/3 of the patient relapsed. But in this study, it was found that the patient discontinued the ICI therapy actually after achieving a complete response, again emphasizing that one should continue for at least 6 months after achievement of the complete response. The primary outcome was the 3-year overall survival. It was much larger in patients who had complete response compared to the patient who did not have complete response. Now, from India, there is one small case series from Bangalore in which it was found that the patient who had achieved the complete response after the A+B therapy, and because of the financial reasons, if they were started on the lenvatinib, it has got a good outcome as well. As we can see, 35 patients were there who received A+B therapy. 25% patients achieved complete response by the analysis criteria. 4 were started on the lenvatinib because of the financial reasons, and median overall survival in these patients was 28 months, and all of these 4 patients maintained the complete response without any recurrence. Now, since ICI therapy is actually not curative and it is costly as well, it is not free from side effects, so we really require the predictors, who are the patients who are going to respond in the long run, who are the patients who are going to achieve the complete response. So these are various tissue-based and the cell-based biomarkers which are in the pipeline, but none of these as of now is in clinical use because of the varied results in the various studies. Now, coming to another issue, whether the ICIs can act as adjuvant or the neoadjuvant therapy, because we just saw the recurrence-free survival was close to 50% only at the end of 3 years. Now, in the adjuvant setting, there was an initial trial, the STORM trial in 2015, in which the patient who underwent resection of the SCC were given sorafenib, but it was a negative trial. Now, recently the IMA 50 trial has been published. The interim analysis showed a good response that these patients are going to have an improved recurrence-free survival. But when the final analysis of this came, it was found that compared to the active surveillance, the A+B therapy had got no advantage with regard to the recurrence-free survival or with regard to the overall survival. So this was again a negative study. So adjuvant ICI therapy as of now is not in use and has shown persistently negative result. There is just one small phase 2 study of suntilimab in which it was found to be positive, but the follow-up period was very less and it was just a phase 2 study. Now, in the neoadjuvant scenario, the ICI therapies have got somewhat more advantages compared to adjuvant scenarios. It can cause downstage of the tumor. It can make the tumor resectable or transplantable. And also, there is a difference between the functioning tumor and the micrometastasis. The functioning tumor is large in size mostly, and it can be more immunogenic and can enhance the activity of the ICIs when they are giving subsequently, somewhat what happens in the neoadjuvant scenario. Compared to the adjuvant scenario where the tumor has been removed and they are just micrometastasis, in that scenario, the micrometastasis may not be strong enough to elicit the immune response, and this may be the reason of the failure of the ICI therapy in the adjuvant scenario. However, this is just a hypothesis and has not been proven. And there are very small studies, the phase 1 and phase 2 studies in the neoadjuvant scenario, and all of these studies have used the pathological endpoints as a surrogate of the overall response. As we can see here, neoadjuvant semipilimab in resectable SCC is a phase 2 study. Resection also is one of the curative intent, but has got a very high recurrence rate of close to 70% in the long run at the end of 5 years. So it is very understandable that this study was carried out. The primary endpoint was the significant tumor necrosis, which was defined in this study as the more than 70% necrosis of the resected tumor, and it was achieved in close to 20% of these patients. And 3 patients actually achieved 100% necrosis, which is a good figure. And it was found that there was increase in the tumor infiltrating lymphocytes in the patient who had good response compared to those who did not have good response. And another interesting study, we have compared the combination therapy, that is nivolumab, anti-PD-1 inhibitor, with ipilimumab, that is anti-CTLA-4 inhibitor, and they have compared it with the nivolumab monotherapy in resectable SCCs. And the primary outcome of this trial was the grade 3 or 4 IRAEs, that is the adverse events because of this ICI therapy, which was more in the combination arm compared to the single arm. And interestingly, 33% patient, that is 3 in each arm, achieved major pathological response, that is more than 70% necrosis in the tumor. And 5 out of 6 patients had a complete response. On ISC analysis, it was found that there was an increase in the immune cell infiltration in the patient who had a good response. Now this study is special in 2 forms, that the combination therapy actually, when this patient was going for the trial, they had a biopsy done in the tumor prior to treatment. In this, there were no tumor infiltrating lymphocytes present at the prior to the therapy, but when the patient received the therapy and subsequently the tumor was analyzed, it was found there was an increase in the immune cell infiltration. Therefore, it was speculated that this patient had initially a poor biology of the tumor was there, and which was even in those patients also, the combination therapy, although there was no side effect, but it could achieve a success rate of 33% patient despite having poor biology. And this is one of the few trials in which a long-term outcome of the patient has been assessed. At the end of 2 years of follow-up, there was no recurrence of the tumor who had a major pathological response, compared to nearly 50% of the patients who had recurrence of the SCC in patients who did not have major pathological response. Also, the combination therapy in the form of cabozantinib and nivolumab can convert a locally advanced unresectable SCC into a resectable one, as we see in this small case study. 80% of these patients underwent successful margin negative resection, and 42% patient had a major pathological response. And these patients had a good percentage of disease-free survival as well. This is a recent meta-analysis published, 96 patients from 5 trials, and the pooled pathological complete response was close to 15%. Pathological response was close to 1/3 of these patients, and the recurrence-free survival are close to 50%. Now, what about the neoadjuvant therapy with regard to the liver transplantation? Because liver transplantation offers the cure of these patients with regard to the SCC as well as the underlying liver disease, underlying cirrhosis as well, and this holds great promise, and this is a burning issue right now to increase the clinical utility of the ICIs even in the neoadjuvant scenario for liver transplantation. Initial concerns were there regarding the risk of graft rejection, because PD-1 pathway is one of the most crucial pathways for graft acceptance, and there were in fact several fatal case reports of acute graft necrosis as well in patients who had been given ICI therapy in the neoadjuvant scenario for prior to liver transplantation. So this is a very recent study. The intention to treat outcome of patient with SCC who received ICI therapy before liver transplantation from 6 US high volume academic centers. Out of 117 patients analyzed, nearly 73.5% patients, nearly 3/4 of these patients exceeded Milan criteria, and this therapy was given to downstage the tumor to enable them within Milan criteria. Most common ICI use was the nivolumab and the A+B therapy. Median cycles was 8, and median duration of treatment was 8 months. Even in this difficult to treat scenario, nearly 3/4 of these patients could be successfully downstaged to within Milan at the end of 6 months, with 20% patients achieving complete response and 35% patients achieving partial response. And out of these, 43 patients went ahead with liver transplantation, including 3 LDLTs. The 3-year ITT survival of the overall cohort was quite good, 70%, and the 3-year post-liver transplant survival was also very good, 85%. There were just 7 rejections, and interestingly, Out of these 7, 6 patients had received ICI therapy within the 3 months prior to the liver transplantation. 5 recurrences were there. All had SCC at the time of transplantation within the Milan criteria, but a relatively higher AFP value, again emphasizing the importance of the tumor biology, not just the number and the size of the tumor. And as discussed, the post-LT survival was close to 85% at the end of 3 years, and the intention to treat and survival of the whole cohort was close to 70%. Another retrospective study just published, it was a retrospective study analyzing nearly 120 patients from 6 US centers, and to determine the safe washout period for ICI prior to liver transplantation. And in this study it was found that the 50-day washout period was optimum one, so as to minimize the risk of graft rejection, which was close to 10%, that is somewhat equivalent to the ICI naive patients, and also to reduce the risk of graft rejection, to reduce the risk of SCC recurrence also. It was close to 25% at the end of 3 years. So according to this study, at least 50 days washout period should be given. And this is a systematic review and the meta-analysis of 30 studies in which 91 patients were analyzed. Median follow-up was 2 years, and the graft loss and the graft rejection was seen in nearly 25% of these patients, including graft loss in 4 patients. And interestingly, in this study, it was found that for every 10-year increase in the age of the patient, there was a reduction in the graft. Rejection rate by 28%. So the elderly patients actually are having less rejection risk compared to the younger ones. And every 1 week increase in the ICI washout period also reduced the risk of graft rejection by 8%. And according to this meta-analysis, 90-day washout period was the optimum one, so as to minimize the risk of graft rejection. Now coming to the risk of SCC recurrence, fewer the ICI cycles, more was the chance of recurrence, 4 versus 8. There was an inverse correlation between the ICI cycles and the ICI washout period with the retreat score. Retreat score is actually a composite score made up of 3 components and is a predictor of the SCC recurrence after the liver transplantation. It includes the AFP value at the time of transplantation, the number and size of the tumors, and also the presence of microvascular invasion in the histology. The more the score, more the risk of SCC recurrence. So there was an inverse correlation of the ICI cycles. That is, if the cycle is less, higher the score, more the recurrence risk. Also the ICI washout period, lower the washout period, higher the score, and more the risk of the SCC recurrence. Again, emphasizing that the tumor biology can be assessed in the washout period. If there is any worsening of the parameters, then these patients may not be a suitable candidate for the liver transplantation. And also the post-ICI completion SCC, if it is beyond the Milan criteria, there is a risk of SCC recurrence. Larger the size of the tumor, the more the recurrence. Now coming to the issues related in the post-LT period, actually Dr. Satyendra, Dr. Ashok can advise further. And just very briefly, peri-LT liver plasmapheresis is an option to mitigate the risk of rejection, especially in cases with short ICI washout period. TAC is a pro-oncogenic, so the concentration of the TAC should be minimized in the early and the late phases as well. And consider the addition of mTOR inhibitors such as everolimus because of their endogenous anti-cancer property, and it can also reduce the risk, reduce the doses of the TAC. So both ways it is going to be beneficial. Now selecting the patient for downstaging prior to liver transplantation. These are the general criteria. It can be morphometric criteria, that is the UCSF up to 7, extended Toronto criteria, the all-comers criteria. But these are the morphometric criteria. They do not take into account the biology of the tumor, except the ETC, that is the Toronto criteria, which requires the biopsy of the tumor, and if there is G3 tumor, then it is excluded. The AFP and the PET-CT, these are very important biomarkers to predict who are the patients who could undergo downstaging. AFP value, if it is high in the beginning, especially if it is more than 1000, then very less chance that this patient is going to have successful downstaging, less than 20% chance. And the PET-CT is also a very useful marker, especially it has been analyzed in the LDLT scenario from the Asian, specifically from the Japan and the Korea. If the SUV ratio, tumor versus non-tumorous region, it is more than 1.2 or 1.4 in certain studies, then it is a predictor of microvascular invasion and a G3 tumor, and is having poor prognosis. Finally, the response to the downstaging. If the patient is having a decrease in the AFP and the DCP, then it is a good response. But if it's again increasing, in certain studies it has been shown that AFP increase by at least 15 nanogram per ml per month is a poor prognostic marker, and these patients are actually going to have a poor outcome after the transplantation. Also, in certain studies, the PIVKA2 and the L3 fraction, PIVKA2 more than 7.5, L3 fraction more than 15% is in fact a better marker in certain studies compared to the eosinophil protein. MRI is also useful. It can, the peritumoral arterial hyperenhancement and washout in the hepatobiliary phase is a marker of the microvascular invasion, and differentiated MRI can also be useful. And finally, the tumor biopsy can be done, targeted biopsy, to see whether it is a G3 tumor or having a good prognosis. And these are all the methods with which we can choose the patient who should undergo downstaging prior to the liver transplantation. And this is a suggested algorithm which has been made analyzing the various studies, and it is open to discussion and further improvement because there is very little data regarding the patient who achieve complete response. How should they be managed further? So if a patient has achieved a complete response to the ICI-based therapy with or without local regional therapy, and we assume that the patient is having good child score, child A or child B7 at the most, and a good performance status. The most important thing, the first thing that should be determined is the age of the patient, because we saw in the study the overall survival is good in these patients despite having a high recurrence rate. So if the age is more than 70, we can continue with the ICI with or without local regional therapy. And these two therapies actually are synergistic, as we just discussed, and this has been shown in the recently published EMERALD trial, published in Lancet this year only, in which the isolated local regional therapy had a poor response compared to the combination of the ICI with the local regional therapy. But if the age is 50 to 70, we can go ahead and plan for liver transplantation if possible. And at the baseline, we should see what is the baseline AFP value and the FDG PET values. And if these are favorable, and we can also see the kinetics of the AFP during the treatment the patient had undergone. If it was favorable, then it is good. And also we can utilize the values of the PIVKA2, AFP, L3. How has been the response to downstaging? This is also very important. The patient had responded promptly, requiring fewer number of cycles for achieving a complete response. It is a good marker. The tumor biopsy and the MRI can also be helpful. If all these results are favorable, then we should hold the ICI for 3 months, the washout period which is required. And if during these 3 months the patient had shown favorable AFP kinetics and the PIVKA2 levels, then we can go ahead with liver transplantation. However, if at any point of time these markers have been unfavorable, then these patients should be continued on the ICI-based therapy with or without local regional therapy. Now, if the age is less than 50 years, because increasing age at risk is a protective factor, age is less, then there is a risk of graft rejection. Then, if the age is less, and preferably the combination ICI therapy should have been used because it increases the chance of the major pathological response. If the bevacizumab had been used, stop it 6 weeks prior to the surgery because it hampers the wound healing and causes infections. And after this, we can go ahead with resection. We analyze the tumor specimen, the surgical specimen. If it is showing the complete pathological response or the major pathological response, then there is quite high chance that this tumor is not going to recur, and we should monitor this patient. But if the complete response is not there, then things become really difficult. Either we can continue the ICI therapies, because even in the neoadjuvant scenario, that positive studies that we have seen, actually in some of these studies, it was giving pre and post both. So we can continue the ICI therapies. We can go ahead with liver transplantation, or we can wait for the various trials which are now ongoing in the adjuvant scenario to wait for the results. However, this is open to discussion and further refinement is really needed because of very little data as of now. To conclude, a small proportion of patients with advanced SCC actually achieve the complete response to ICI-based therapy, and these patients have an excellent survival. However, the risk of SCC recurrence is a concern. And if considering the discontinuation of ICIs, treat for at least 6 months beyond the complete response to minimize the risk of recurrence. And ICI with local regional therapy has shown promising results, and further studies are needed for exploring the ICI in the neoadjuvant or the adjuvant scenario in the setting for the resectable SCCs. And pre-LT ICI use may become a reality in the future and will expand the patient pool available for the liver transplantation.